Hi, good evening. I see a lot of familiar faces in the crowd tonight. Welcome, nice to see you. Yeah, thank you for coming out. So Brooke and I are happy to give, this is our second talk. Last year was our first talk, last February. It is Heart Health Month, so we'll be doing this series ongoing here with the hospital. But today we decided to talk about atrial fibrillation, which I'm sure many of you are familiar with, but we're going to go into great detail if you're not. But just to get started, we have no disclosures or conflicts of interest. We don't receive any financial grants from major pharmaceutical companies or device companies. The recommendations we'll be going over tonight are those coming from the American College of Cardiology and the American Heart Association. Those are the main professional bodies for cardiology, as well as using our own clinical experience and clinical judgment for some of the strategies we've used successfully in the past. So just to give you a brief overview of what we're going to talk about tonight, we're going to start by talking about some definitions and pathophysiology. What is atrial fibrillation? Where does it come from? We'll talk a little bit about the epidemiology and the impact of a diagnosis of atrial fibrillation. We'll talk a little bit about the risk factors for developing atrial fibrillation, symptoms and diagnosis, atrial fibrillation and stroke, which is a very important topic. We're going to talk about treatment, which can be a very large topic to talk about. And then if there's time left at the end, we'll answer some questions for you. So just to jump right in, what is atrial fibrillation? And this is, when I'm seeing a patient with a new diagnosis in the clinic, this is usually one of the first questions they have. So atrial fibrillation is an abnormal heartbeat coming from the upper chamber of the heart, the atrium. I'm going to use this slide for a second here. So sometimes it's easier to talk about what's normal before we talk about what's abnormal. So normally what's going on in a typical heart is you have a little bunch of cells up here in what's called the right atrium, the upper chamber of the heart, and that's the sinus node of the heart. That creates an electrical signal. That electrical signal propagates across the upper chambers of the heart and it makes them contract in a coordinated fashion. So those contract and they squeeze blood down into the ventricles, these chambers down here. That electric signal has got to go through a little gatekeeper here, the AV node, and that's going to be an important thing we'll talk about tonight. And that gatekeeper allows that electrical signal to come down to the ventricles, the big muscular parts of the heart that then squeeze and create a heartbeat. So that's when things are working well. What happens with atrial fibrillation? Well, there's areas in these upper chambers that kind of go haywire. Little ectopic electrical activity that starts firing like a firestorm. And it goes very, very fast. It can go up to 350 beats a minute. Those electrical signals bombard across this upper chambers, the atrium, and instead of nice coordinated squeezing, they kind of shake or fibrillate. And that's where we get the term atrial fibrillation. What happens, unfortunately, is that they bombard that gatekeeper with hundreds and hundreds of beats per minute of electrical signals. Thankfully, this gatekeeper's job is to prevent all those signals from coming down and making the heart go too fast. It's not perfect, however. And so, a lot of these heartbeats will get down and they'll cause the heart to beat rapidly and irregularly. And so just popping back, this is kind of a visualization from our friends at the CDC here, kind of give you an idea of that kind of discoordinated electrical activity. When we talk about atrial fibrillation, we like to categorize things to help us have a universal language. And so you'll hear the term paroxysmal atrial fibrillation. And what that really means is these are discrete episodes of atrial fibrillation that can come and go. If they're lasting less than 7 days, we typically call them paroxysmal atrial fibrillation. Episodes that go on longer than that we'll call persistent atrial fibrillation. And these episodes can go on for weeks, months. Oftentimes will require some sort of intervention to get you out of it. But some patients do have spontaneous conversion out of this after months or even years of atrial fibrillation. It is rare, but it can happen. Episodes that go on longer than a year, though, we typically consider long-standing persistent atrial fibrillation. And we use the term permanent atrial fibrillation when the physician and the patient have made the decision that further attempts at trying to get back into a normal rhythm are unlikely to be helpful or successful. And when we said, okay, enough's enough, we're going to just stay in atrial fibrillation, that's when we use the term permanent atrial fibrillation. I am going to just talk a little bit briefly about atrial flutter. So sometimes the terms will be used interchangeably. They're actually kind of two different things. I jokingly call them cousins. Atrial flutter typically, but not always, typically comes from the right atrium. And it's kind of this circuit or this loop where there's electrical activity that's stimulated here and it goes around and around and around. And every time it comes around, it's activating that gatekeeper, that AV node. So it's fast, but tends to be a little more regular than atrial fibrillation. It is similar in that it can also carry some risk of stroke. It can make the heart go very fast, feel very irregular, where atrial fibrillation typically comes from the left side, although it can come from the right side of the heart. Atrial flutter looks a little more organized on an EKG here. So you have these typical sawtooth pattern on your EKG, where atrial fibrillation is kind of a little electrical chaos here. There's no clear rhyme or reason and less likely to be regular. I like to think about the history of things. When did we start, noticing this? And as I was preparing for this talk, I said, well, when was atrial fibrillation first documented? And there's references to it going back to ancient Chinese texts from 2000 BC. If you go back about 5 centuries, they started observing atrial fibrillation in animal models. Unfortunately, the animals were alive and open at the time. Our understanding of atrial fibrillation really improved with the development of the electrocardiogram, and the first electrocardiogram with atrial fibrillation on it was obtained in 1906. Improvements in our understanding of atrial fibrillation really came through the 20th century with the development of what are called electrophysiology studies. So these are studies where wires, catheters, are put inside of the heart to measure the electrical activity. And even more recently, in the 1990s into the early 2000s, electrophysiology studies became better at pinpointing exactly where atrial fibrillation came from in the heart. Going back into the mid-last century, I should say, started to recognize the relationship between atrial fibrillation and stroke. So who gets atrial fibrillation? The sad answer is a lot of people. Atrial fibrillation is very common. So studies back in the early 2000s thought that by 2020, 3 million Americans would have atrial fibrillation. Unfortunately, they were off by quite a bit. Most recent estimates are closer to 10 million individuals, about 1 in 22 adults. Wow. Yeah. That actually number increases that as we age. So in a demographic that would look something like this room tonight, it might be closer to 1 in 4. Why is this increasing? We're an aging population. Atrial fibrillation increases with age. So as the population gets older, we see more atrial fibrillation. It is associated with obesity. So as our population is getting heavier, we're seeing more of that. And to some extent, improved detection. We're more aware of atrial fibrillation. We're looking for atrial fibrillation more, but we're catching more of it, so the incidence is increasing. It is more common in Caucasian populations, and study after study have kind of shown that. It is, unfortunately, gentlemen, more common in men than women. And estimates suggest about 11% of cases in the US are undiagnosed, meaning people are out there with atrial fibrillation that don't know it yet. Pardon me. This data is a little old. These are sort of old estimates here, but you can see as time goes by, the incidence of atrial fibrillation increases. Men continue to outstrip women. Caucasian populations are still the most affected. And again, age is probably one of the biggest predictors. This is more recent data coming up to more recent data coming up to 2019, and again, age being one of the major predictors. But one of the funny things is you are seeing younger populations start to be represented more. It's minor, but present. So what is the impact of atrial fibrillation? Atrial fibrillation is a major contributor to morbidity and mortality. A diagnosis of atrial fibrillation has a 2-fold increase in the risk of death, a 5-fold increase in the risk of heart failure, and a 2.4-fold increase in the risk of stroke. And data from looking at Medicare beneficiaries with a new diagnosis of atrial fibrillation found some of the major outcomes in the next 5 years for those patients were mortality, 48.8%, heart failure at 13.7%, and stroke at 7.1%. Other things like heart attack, recurrent hospitalizations were also more common. Question, of course, is always, is this correlation or causation? It's an older population that is more likely to have atrial fibrillation. It's patients who have comorbidities like heart failure or diabetes that are more likely to be affected. So is atrial fibrillation causing this, or is it just this population is an older, unhealthier population? There is some data coming out of Europe that has suggested that independent of these other illnesses or risk factors, atrial fibrillation still confers increased mortality, heart failure, et cetera. So it's a significant disease process, and we're going to talk a little bit about how we uncover that and how we treat it.
All right, I'm going to talk a little bit about risk factors. Some of them we touched on a little bit here. How do I use this? Okay, got it. All right. So when we divide the risk factors, we talk about modifiable, so things that we can fix, and non-modifiable, things that we cannot fix. So things that we can't fix would be aging. This will happen to all of us. So the older we get, the more likely we would be to develop atrial fibrillation. Gender, we talked about, men are more likely to develop atrial fibrillation than women. Also race, talked about Caucasian as well. Genetics do play a role. We'll see people in the office who are quite young, and we say, why do you have atrial fibrillation? Turns out, maybe both their parents or their younger siblings also have this. There have been some genes identified to have a correlation with this. Heart failure. So this could be people who have what we would call as a cardiomyopathy, a genetic cause. Maybe this was related to a virus they had. This can also be someone who's very sick in the hospital, who's developed acute heart failure. So they've developed a lot of congestion around their heart, and these people are more likely to develop atrial fibrillation while they're inpatient in the hospital. So there's other acute illnesses as well. The flu, COVID, pneumonia, that would not be an uncommon thing to see when someone is very ill. They come in to be checked out, and they're found to be in new atrial fibrillation. Surgery would be something we also see a lot. Very common for cardiac surgeries. These are often seen with open heart surgeries. People that have bypass surgeries, need a valve replaced. There's a lot of tinkering going on in there, and so developing atrial fibrillation is not uncommon. And sometimes when they leave the hospital, they're put on a medication so that this doesn't come back for maybe 1 to 3 months, depending on the case. What we also see is surgeries that are non-cardiac. This can be anything from a hernia surgery to, commonly we see this with colonoscopies. And this is often because people will be dehydrated. You get that really yummy juice before you come in for that. You have electrolyte abnormalities. They go to put you on the EKG, and they see that you're now in an atrial fibrillation. So things that we can fix: high blood pressure. This is commonly associated with atrial fibrillation. Alcohol. There is a term called holiday heart. Someone may go on vacation, they drink a lot of alcohol. Afterwards, they notice their heart's racing, and they've been found to be in atrial fibrillation. People that do already have atrial fibrillation, which we'll probably talk about later as well, may say that I feel good most of the time, but if I have 2 glasses of wine, I start to go in an AFib, and my heart starts to race. So this can be a very common trigger. Sleep apnea, very common, very prevalent among people who do have atrial fibrillation. Me and Dr. Spencer feel that we support the sleep medicine department in the state of New Hampshire with the amount of referrals that we sent out. And we do see it a lot. And there are a lot of studies that say these people have had their AFib fixed with something called ablation, which we'll talk about. And the people that use their CPAP and have treated that do much better. They are not getting AFib again. And so a lot of times when you see someone who wants to try and get you out of AFib, they want to see that you're willing to do something like wear a CPAP, reduce your alcohol intake, exercise, reduce obesity. So obesity, increasing weight increases the risk. An overactive thyroid would also be a common thing that we find, which can sometimes be a relatively easy thing to fix. And then diabetes. So high blood sugar is associated with an increased risk of burden or amount of atrial fibrillation, as well as the development of atrial fibrillation. So as far as symptoms, this is pretty variable. It's hard to say what one symptom someone will come in with. As mentioned, there is a lot of undiagnosed atrial fibrillation, and my guess is most of those people don't have symptoms, and we see that a lot. There's a lot of variability that we'll see in cardiology. We will have, we'll say for example, a 60-year-old gentleman comes in, he's going 160 beats per minute in atrial fibrillation. He feels great, he's having a great day, he can't tell, he doesn't have any difference to him. But we may have, let's say, a 60-year-old woman who comes in, she's in AFib, her heart rate's good at 75, but she feels horrible. And so there can be a lot of variability there. Most common thing presenting is palpitations, people feeling their heart is racing. They might feel dizzy, lightheaded, might feel more short of breath with walking to up the driveway to the mailbox. And sometimes this can be more severe, things like chest pain. And interestingly enough, something we often do see is people say that when they're in AFib, they urinate more, which is interesting. The more severe or more concerning thing to present with would be a stroke. So they've now developed a stroke, and we find that they now have AFib. This would also go for someone who's had maybe a rapid heartbeat of 150 beats per minute for the last 3 weeks, and now their heart muscle is worn down and tired, and they've now developed heart failure. And so those would be the more severe presentations. All right, so diagnosis. Most commonly this would be with an EKG, and that's the test where we put the stickers on the chest. Often this is noticed when someone's coming in complaining of any of those numbers of symptoms that I discussed. Normally someone would listen to your chest with a stethoscope and see that your heart rate is irregular, probably fast, and get an EKG. And that would normally be the first step. Following this, we do other kinds of monitors. There's sort of Holter monitors, or we use what's called a Zio patch, which is looks like a large Band-Aid that's placed on the chest for 2 days to 14 days. Some facilities do up to a month, but this monitors the heart rate and rhythm for that period of time. And this would tell us how fast is the heartbeat, what is your heart doing at the time that you're telling me that you're dizzy, how often are you in, let's say, AFib, do you have any pauses or concerning findings there. So that can be another way that we look for this. An implanted loop recorder. Has anybody heard of an implanted loop recorder? Okay. I have one in my pocket here, so I'm going to pass it around. So frequently this is a place for what's called cryptogenic stroke. And that's just a fancy way of saying you have a stroke and we don't know what caused it. This is a small device that's placed underneath the skin. And it monitors the heart rate and rhythm for 3 years. So this can be a really helpful tool. A lot of the studies do show that the longer this is in, and let's say 2.5 years down the road, we find AFib. It's probably not what caused the stroke, but I guess it's hard to know for sure. It is still found. So these are helpful. They're good for 3 years, and they don't do anything. So they don't like a pacemaker. They don't pace. They just watch. So I'll pass it around. There you go. Okay. Where was I with that? So, and those can stay in. So some people just leave them in after they die, and sometimes they remove them. So the last thing would be wearable devices. So things like Apple Watches, sort of the Cardia apps, all of those sorts of things. And those can be really helpful in detecting maybe an irregular rhythm, or why do you have such a fast heart rate when you're just sitting down. There isn't a lot of great data supporting how beneficial this is in the diagnosis and how this affects long-term outcomes. So for us, we're sort of waiting for a lot of that data to come out. That being said, some limitations on that is if anyone's ever looked at these before, it can have a lot of what's called artifact, so it's just kind of a lot of wild looking EKGs, which are hard to interpret. But it can be really helpful for people that want to take accountability and empowerment in their own health. People have noticed that when they start to decrease some of the risk factors, like let's say alcohol or exercise more, and they notice that they're having less AFib, that can be really empowering. So there are some positive things that go along with that. And then this is just a slide that talks about really the important pillars of atrial fibrillation, the lifestyle modifications, which we touched on, anticoagulation, which we'll get to, and the ways that we treat this, which is a rate versus rhythms technique, but really all over the importance of assessing and optimizing those risk factors and treating the cause and preventing further burden of atrial fibrillation. Okay, so I'm going to talk a little bit about stroke. This is a CT, and this is an enlarged left atrium, and this is a clot within the atrium. I know that there's a thing, but I don't know how to use it. So it's right here. The part of the heart in which AFib comes from, as Dr. Spencer spoke about, was the left atrium. All right. So why does a clot form within that particular area? One of the things I like to describe to patients in the office is that you really just have the top part of the heart and you have the bottom part of the heart. In atrial fibrillation, you get sort of this wacky fibrillating, and you're not getting a full squeeze. And so when that happens, you get a pooling of blood. And when that happens, clots form, and it travels down to the bottom out to the body, up to the brain, causing a stroke. So the area of that normally happens is called the left atrial appendage, which we'll talk a little bit about. This was just a journal that is really interesting. So this was from 1990, which is really not very long ago, but this was one of the first journals to identify the benefit of anticoagulation, and this is warfarin specifically, and its ability to reduce stroke in patients with atrial fibrillation. So who gets anticoagulation? There are a lot of different scales. The most common is this scale, which is called the CHADS-2 VAS score. And the scale goes on a number scale from 0 to 9, 0 being the lowest, 9 being the highest. The higher your number, the higher your risk of stroke. So for being a female, there is increased risk, thromboembolic stroke in patients that are female, so you get a point for that. The older you are, you get either 1 point or 2 points. Over 75 is 2. If you've had a stroke, there's 2 points. And then the other comorbidities are heart failure, high blood pressure, diabetes, or vascular coronary disease. And so what we do those numbers is basically in women, if you have 3, and in males you have 2, we say that you should be on a blood thinner. These obviously carry a risk of bleeding as a side. So we have to sort of risk and benefit. The benefit from being on a blood thinner in that population is higher than worrying about bleeding. There is an intermediate group where it's a male with 1. So let's say you're a young male with high blood pressure, or you're a female with 2, you're a young female, you're 60 with diabetes. The risk of that is really questionable, and there's not a lot of great data on that. And so how we approach that is with what we call shared decision making, meaning we sit down with the patient, we talk about, here is your risk of a stroke, here is your risk of bleeding, and sort of discuss what is best for them based on their lifestyle, our experience, and we decide together, do we do it now, do we wait, etc. And one of those tools, I'm just going to jump to it here, is called the Spark tool, which is online. I just sort of made up a random patient here who's a female who's, let's say she's 67, she's got high blood pressure and diabetes. So her CHADS VAS score is 4, which would indicate she should be on anticoagulation. This does also have a bleeding risk score, which I didn't use, but can be really helpful for people who have a history of, let's say, liver dysfunction, kidney dysfunction, or major bleeding. But what this will pop up with is a graph which will tell you the risk of stroke with doing nothing versus the risk of stroke being on any number of these blood thinners. The one I just highlighted is Eliquis or apixaban, which is the one we use the most frequently. And so in this particular patient, her risk of stroke every year would be 7.3%. So if there were 100 of her, 7 would have a stroke and 93 would be fine. Although that doesn't sound like very high odds, it's high enough for us. On Eliquis, this would reduce the stroke risk to 1.9%. So you get quite a reduction. And then this also includes bleeding risk. All of us as human beings walking around the world have a risk of bleeding, which is 0.4%. And this does increase to 1.7% on something like Eliquis. So you just have to weigh the risk and benefit of both of those things and what's best for the patient. There are people that should not be on blood thinners or anticoagulation, anyone who has active bleeding, anyone who has severe anemia, prior bleeding in the brain, certain tumors, and then often what we see will be people who might be falling a lot at home. Maybe they live alone, they're having a lot of falls, they're hitting their head. We worry about future intracranial bleeding at that point. So there are 2 main groups of blood thinners. One is called DOACs, or direct oral anticoagulants. This would be Eliquis, Xarelto, Pradaxa. Or there is the warfarin or Coumadin. And so those are really the 2 groups. The DOACs work on what's called factor 10. Basically what's to know about that is this is an important factor within the clotting cascade, which produces proteins that help create a clot. So this slows down clotting, hence sort of thinning the blood per se. There are people that cannot take things like Eliquis and do have to stick with the older medication warfarin. And these are people with mechanical heart valves. This would not be a bioprosthetic valve or like a cow valve. This would be someone who had an open heart procedure and had a special mechanical valve placed in their chest. Warfarin has a lot of, at DOAC, some of them do interact with certain medications. We've seen some chemotherapies, in fact. For that reason, you would not be able to be on that either. And what's called mitral stenosis, which is a mitral valve within the heart that gets very, very stiff. And the studies found that people that were on warfarin had less clot formation versus people that were on things like Eliquis or Xarelto. Warfarin, the benefits of this is that it is cheap, it's affordable. The DOACs can be more expensive, and that can be a problem for a lot of people. The issue with it is that it affects vitamin K, which is another clotting factor, which creates proteins and creates clots. But that's also in a lot of the food we eat. So that's in things like spinach or green leafy vegetables. And so people can have those things, but they have to be very consistent about how much they have. And so it interacts with the medication, and they have to have routine monitoring. And the levels has to be checked, what's called an INR, which is just basically how thin or thick is your blood. Below 2 means that it's not really working good enough to prevent stroke. Right. 3 and above, or above 3, would say that you're probably at risk for bleeding because it's too thin. So another major thing is how long is your episode of AFib before you start to be on a blood thinner? If you have 30 seconds or if you have 10 minutes, which one of those people gets an anticoagulant. So there's been a lot of studies. I think you could ask 5, 10 different cardiology providers, and you might honestly get different opinions. I would say that there is a consistent range here, and a lot of it's based on some of this trial. This was the Atrial trial, and they monitored people who had pacemakers and defibrillators, and they measured people that got AFib between 6 minutes and 24 hours. So after 24 hours, they said, you need to be on a blood thinner, you're not in the trial anymore. Okay. And the people that had that, they either gave them aspirin or they gave them Eliquis. And what they found is that the people that were on Eliquis had less strokes, which was the primary endpoint versus aspirin. There was increased risk of bleeding with people that were on Eliquis versus aspirin. None of it was life-threatening. None of it really required any major intervention, all fairly reversible. So really led us to say, okay, for me, patient comes in, they're found to have about 6 minutes. That's usually around what my threshold is. If someone's had a stroke before, and I find that they've had 30 seconds, that might change things, and that seems like a conversation we would talk about risk and benefit at that point. The last thing I'll speak of is what's called the left atrial appendage that I alluded to before. And that's this little structure that hangs off of the left atrium. And this is where most of the clots are felt to form in atrial fibrillation. Sometimes during a surgery, like a bypass or a valve replacement, the surgeon may just sew that up. Which is probably good. There's not a lot of data to say what that looks like in the long term, though. The reason I wanted to talk about it is that there are people that can't be on anticoagulation that we discussed. And so in those people, we often discuss the Watchman device or other left atrial occlusion devices. And this is a procedure where this little parachute guy is basically placed within that left atrial appendage and reduces clot formation. Important thing to know about that is that it is a foreign device in your body, and so you do have to be on some blood thinning device, whether that be dual antiplatelet or an anticoagulant for a short period of time until your tissue grows around that. So someone who is actively bleeding or actively having concerns, this isn't a great option for them. I would also say that at this time, the recommendation is still anticoagulation instead of going straight for something like the Watchman device. I have seen people with strokes with the Watchman device, and I have seen people with clots on it. I would say generally most people do pretty well.
All right, so I think just to kind of give you an idea, if you came into the office and you sit down with me and you have new atrial fibrillation, there's sort of 4 things I want to know up front. So the first question is, why do you have this? And that kind of alludes to the lifestyle things, the risk factor things, structural problems with your heart. Do you have hyperthyroidism? The second thing I want to know is, are you having symptoms? Are you feeling this? Are you feeling unwell? The third thing I want to know is, how fast is your heart rate? Is that under good control or not? And then the fourth thing is, do you need a blood thinner or not, as Brooke kind of alluded to. And so excluding some of those questions, I want to talk a little bit about what we call rate versus rhythm control. And pardon me, I'm just going to skip ahead here to explain this. So when we talk about rate control, we're trying to slow down the heart rate. So atrial fibrillation, if you recall from those earlier slides, the heart's going very fast, and that little gatekeeper there is trying to stop those extra beats from coming down to the ventricle and making it go fast. So that AV node is kind of the target for our intervention here. And we use medications such as beta blockers or calcium channel blockers, sometimes digoxin, that will affect that gatekeeper, that AV node, let it be less reactive or responsive to those signals and slow the heart rate down. That can be enough for some patients. That can improve symptoms, that can alleviate problems. Patients who come in sometimes with heart failure related to the atrial fibrillation, just slowing that down can be enough to improve the function of their heart. The limitation sometimes is really three things. One, it doesn't work. No matter how much medications we give, we can't slow the heart rate down. Two, sometimes the blood pressure won't tolerate it. These medications can all lower blood pressure, and so we'll have patients in the hospital sometimes where we're really trying to push these medicines, but we just cannot get the heart rate under control with the doses that they can take. The third thing is some individuals, like as I mentioned before, have paroxysmal atrial fibrillation. They come in and out of it, and so an appropriate dose to slow the heart rate down when you're in atrial fibrillation might be way too much medication for you when you flip back into a normal rhythm. And that's something we call tachybrady syndrome. Sometimes we use pacemakers in that case to help, if you will, give a safety net to the heart rate so you can't go too slow if you go back into a normal rhythm. How fast, or how slow, I should say, would we consider good control? What's our target heart rate for a patient with atrial fibrillation? A study in 2010 looked at this and asked this question, because previously we were trying to keep people in the 70s and 80s. It turns out that might have been a little too aggressive. So in this well-designed trial, they basically said, let's let some people go up to 110 beats per minute at rest, and other people will try to keep under 80. There was no difference in outcomes as far as, heart failure symptoms, these sort of things. And they did find that more people had side effects from the tighter control. So that's kind of rate control in a nutshell. And it's usually, a first line while we're still gathering information about the patient, while we're kind of thinking, okay, what's going on here? What's causing this? One of the first things we do is try to get that heart rate under control. Rhythm control is how can we get you back into a normal rhythm? How can we flip you out of atrial fibrillation? And there's a lot of tools that have developed over the last quarter century. Synchronized electrocardioversion, that's shocking the heart. We'll talk a little bit about that. Antiarrhythmic medications, I've given some common examples here. And then catheter-directed ablation or pulmonary vein isolation. And we'll kind of go through these a little bit. Synchronized cardioversion. Does anyone have any idea when the first cardioversion was done? I looked this up very recently. It was in the Soviet Union in the 1950s. That was the first time this was done, yeah. So basically this is a procedure. It can be done emergently if someone's very unstable, or it can be done electively if the patient's more stable, where we use electric pads to deliver an electric shock that depolarizes the tissue in the atrium. Basically, it's almost like turning off the heart and turning it back on again. It's a relatively simple procedure. I would say the success rate depends a little bit on patient selection, but overall I would say 80%. Now the catch is it might work for a very long period of time. I'm seeing some people who might have experienced this. It might work for a very long period of time, or it might only work for minutes, and then you end up right back in atrial fibrillation. Antiarrhythmic medications are a great tool, and the problem with them, though, is some of them are toxic in certain situations. So patients who have structural heart disease, like heart failure, or have a history of coronary disease, some medications are not safe for those patients to use. It can increase the risk of death. Other times, medications have long-term toxicities. I don't know if anyone here is taking amiodarone, but amiodarone is a very effective medication for maintaining sinus rhythm. There can be long-term toxicities associated with it that can affect the thyroid, the lungs, the eyes, etc. So sometimes these things will limit the use of these medications. They can also be proarrhythmic in certain settings. So these rhythms, these medications can trigger more dangerous ventricular rhythms, rhythms from the bottom part of the ventricle. So we end up having to closely monitor these patients with EKGs and blood work to make sure there's no toxicities. Catheter ablation has really become a mainstay of the rhythm control strategy. In the next subsequent slides, we're going to talk a little bit about that. But catheter ablation basically is an invasive procedure where special cardiologists called electrophysiologists will take catheters and go up through a vein in the groin, come back up to the heart on the right side, poke a little hole across to get to the left side of the heart, and then they'll map out where the atrial fibrillation is coming from, and using that catheter, burn to electrically isolate those areas of the atrium. This first came into practice in the right atrium for atrial flutter in the 90s. It wasn't really until the mid-2000s that this started becoming more common. And the idea basically is that if there's an area with atrial fibrillation and you burn around it, it's almost like a fire break, if you will. It prevents the electrical signal from propagating across that tissue and going on from the body. Sometimes it requires more than one treatment. Success rates, again, depend a little bit on patient selection. And we'll talk a little bit about that. This is just an example of what I was describing for you. There you access the groin, coming back up to the heart in the right atrium. So this vein comes back up to the heart, and they poke a hole in what's called the intra-atrial septum here and try to isolate the pulmonary veins. And that's why you'll see the procedure called pulmonary vein isolation. There's some very interesting research done in the mid-90s that suggested this is primarily where atrial fibrillation comes from. So when I got out of training in 2015, the guidelines were basically there's not clear advantage to rhythm control over rate control. So unless there is some reason why you're really compelled to try to put this person back into a normal rhythm, rate control is absolutely fine. And these guidelines came out of a series of studies done in the early 2000s that basically showed there was no significant benefit to rate control versus rhythm control. So whether or not I kept you in, as long as you were asymptomatic and well controlled, basically the guidelines said, you know, there's no compelling indication to try to get you on these medications or do ablations. Now, inevitably there were patients who were difficult to control, still had symptoms despite adequate rate control, and in those cases, you know, we'd pursue medications like the antiarrhythmics or ablations, but generally speaking, the thought process at the time was, if you're under good rate control and you're feeling well, don't do anything. That has shifted over time, and that has mostly been through advances in ablation techniques. And this was a trial comparing antiarrhythmic drugs to catheter ablation. Ablation seemed to be better than the antiarrhythmic drugs, so the question became, all right, well, if that was the old standard and this is better than the old standard, should we change something? So this is another study that started to, for the first time, show a benefit in patients who had been in atrial fibrillation for less than a year. Again, patient selection is important, but in this group of patients, they saw benefits to an aggressive approach to maintain sinus rhythm rather than just rate control the patients. So in a meta-analysis that was published this 2 years ago, basically showed that when you looked at a large group of trials, the trend was towards less death, heart failure, stroke in patients who had rhythm control, meaning maintaining sinus rhythm rather than rate control. And what's really interesting here is that you can see in this graph, this is basically what percentage of the patients in the trial had an ablation done. And so the best outcomes for the patients in these trials were the trials that used catheter ablation primarily and used medications as kind of a backup. The earlier studies really showed no benefit. So that has changed our approach now to thinking about rate versus rhythm control in atrial fibrillation. Now the guidelines haven't changed completely. The most recent updated guidelines were published in 2023. Some of this data is still a little new, and things kind of move slow sometimes in medicine. But I think the important thing to get here is when we're thinking about rate control versus rhythm control, it is a very patient-specific. And so if I'm seeing a younger patient coming in with new atrial fibrillation, up front, I think we should be very aggressive at trying to get them back into normal rhythm, and that would include things like cardioversions, antiarrhythmic medication, while trying to get them in for an ablation, because I think in the long term, that offers sort of the best success of keeping them in sinus rhythm. If someone comes to me and they've been in atrial fibrillation for 42 years, the probability of us getting them out of atrial fibrillation at that point, even with really aggressive procedures and medications, is low, and the risk of harm increases with that. And so these are some of the factors that we look at. You know, how well how well the atrial fibrillation is tolerated. Are you having a lot of symptoms? Are you in heart failure? Is your heart failure well controlled? These are all factors that go into trying to make these decisions on which strategies we can use to treat these patients. I'm just going to kind of hammer home here because we talked about it a lot, but the lifestyle modification. And as I said, you know, when I sit down with a patient for the first time in the office, and my first question is, why did this happen to you, right? Because if there's anything we can change to prevent this from going on, that's probably the most important thing we can do. And as Brooke mentioned, I think we order more sleep studies than anyone else in the hospital. So really, really focusing in on this. So I think the GLP-1 inhibitors are going to be really huge for cardiology in aiding in weight loss that will prevent atrial fibrillation. Really aggressive management of things like diabetes and blood pressure have been shown to be helpful. So there is obviously all the things we're going to do with medications and procedures, but there are these lifestyle things. So believe it or not, exercise. It sounds kind of counterintuitive. You don't want your heart rate getting fast, but exercise has been found to be helpful. Treating sleep apnea, as we've talked about, improving glycemic control. Believe it or not, even improving cholesterol. There's been some evidence that I'll allude to in a minute. Caffeine's one we get a lot of questions about. Should I have more or less caffeine? Not a lot of evidence for that. I do have patients where there's a very clear association. They have a cup of coffee, they go into atrial fibrillation. So to them I say, I'm sorry, that's it. Chocolate is another common one. Patients will take chocolate and that triggers their atrial fibrillation. I say, I feel very bad for you. I'm sorry, But really, diabetes, hypertension, alcohol, weight loss, sleep apnea, these are just as important tools as the phthalate, sotalol, and cardioversion. These are really important. A series of trials looking at this. Basically, what you're looking at here is freedom from atrial fibrillation following ablation. And this is weight loss, 10% of body weight loss. You see these people stay free from atrial fibrillation for years versus people who failed to lose weight or indeed gained weight. The ARREST trial looked at aggressive risk factor modification. So this is blood pressure, cholesterol, and diabetes control. And again, with that, you see a huge improvement in freedom from atrial fibrillation. CardioFit looked at a combination of weight loss and improvement in metabolic function, so exercise. And while the best group was weight loss and exercise, weight loss without exercise still did well. Exercise without weight loss did okay, and if you changed nothing, they had the worst outcome. So there is a lot of benefit here. It's clinically proven, and so it's an important part of any discussion with your team. So really, just to wrap things up here, if I may, atrial fibrillation is unfortunately very common, and it seems to be becoming increasingly common. It is associated with significant morbidity and mortality, a lot of problems associated with it. The mainstays of treatment involve, rate control, initiation of anticoagulation, lifestyle modification and management of risk factors is, again, another one of those pillars of management of this. Restoring sinus rhythm via procedures or antiarrhythmics can be very important in preventing adverse outcomes in select groups of individuals. Thank you all for coming and listening to us. I hope this was helpful. We have a little bit of time to answer any questions that any of you might have. Yes, sir.
My father was diagnosed with what most of us have heard of, heart murmur.
Okay.
And then I was told years ago I had heart murmur.
Yeah.
And was there any connection between that and then my AFib that I now deal with?
Great question. So if anyone didn't hear that, the question was, is there any association with the diagnosis of heart murmur in atrial fibrillation? The short answer is yes. So thinking back about that left atrium where the atrial fibrillation comes from, dilation of that atrium over time because of problems with valves, which I think will be the topic of next year's talk, so stay tuned. But if there's valvular heart disease, that can cause a murmur. Sometimes that can stretch the atrium and trigger atrial fibrillation. So there is an association between valvular heart disease, heart murmurs, and atrial fibrillation. Yeah. Yeah. Yes, sir.
You mentioned, Brooke, the Apple Watch.
Mm-hmm.
Now, is the data that you get from an Apple Watch or what's the other one?
Well, there's a Garmin, I think, that does it now. There's
Like a Cardia app.
there's a Cardia app on
Yeah.
the iPhone, or yeah.
How valid is the data?
So the data is variable. So there's not a lot of great data to say that using those really improves patient outcomes, or that the data we're getting is valid. And a lot of the problem is that when we look at the tracings from those, they can have a lot of artifacts. They can be really hard to read. And then you also, you have tracings and tracings from days to weeks to months that someone would have to review. However, I would say that there does seem to be some benefit to people that, one, do have atrial fibrillation or another elevated heart rate like SVT. You can see how your heart rate is doing, particularly maybe while you're sitting. If your heart rate's very high, that would be abnormal. If someone comes to me and says, I was told that my Apple Watch kept telling me I was an AFib, or my Cardia app told me I was an AFib, the next step would be to use one of our validated tools, so one of those monitors that I had mentioned. Now, if someone, let's say, has had a stroke and they're really high risk, and I think that they're pretty high risk to have AFib, and I look at the tracing, it looks like it's gone on for quite some time. I might go ahead and let's talk about a blood thinner at that point, but still do a validated test, like a heart monitor. But that's a good question.
The one thing I'll add is those watches sometimes can also suggest if you have sleep apnea, and at the risk of sounding like a broken record, that could be another thing that you could detect from that and initiate appropriate screening. Sometimes, unfortunately, when it works, it works. And sometimes people will bring in tracings that, that clearly looks like atrial fibrillation,
Right.
but I couldn't tell you if you go out and buy an Apple Watch that this will necessarily help. Yeah. Sir, yeah?
If you've had ablation, as I have successfully, is there a rule of thumb as to whether it will return? I mean, a percentage, or likelihood of it returning sometime in the rest of your life?
That's a great question. And so the short answer is yes, there is a chance that atrial fibrillation will return, particularly as you age and get older. How likely that is depends on a couple of things. Obviously, as the slide before suggested, lifestyle modification, structural changes to your heart that might have happened, also technique. So with those catheter ablations, one of the limiting factors is they're really trying to completely, for lack of a better word, injure the wall of that left atrium that can sit right up against the esophagus. And so sometimes your anatomy limits how aggressive they can be with the ablation, and that may have an effect on the success rate. Yeah.
But is it 50%
If
or
it,
90%?
so what I'd say is this. What we'd say was durable relief from atrial fibrillation, which would be like 4 or 5 years, probably 75% success rate, sometimes with 2 procedures. So it might be like 65% with 1 procedure, 75 to 80% with 2 procedures. Now I will say, and I don't quote me on that, because there are new techniques now with what's called pulse field ablation, where they're able to deliver more energy safely, and so those numbers may be improving over time. I'm sorry, yes, sir.
This question is related to Apple Watch.
Yeah.
The question actually is there any kind of convenient, affordable, wearable device that will monitor blood pressure?
I'm gonna say no.
I'm
Yeah.
saying no.
Not that I've come across. No.
I have
Yeah.
not seen that. I've seen
Yeah.
some people that have brought in. There hasn't been any that have been validated by studies, at least that I know of. I have had people bring in some pretty fancy and expensive. I think there's like a ring. There's a watch, and we've actually checked their blood pressure versus what we've seen in the office, and it doesn't seem accurate.
Yeah.
Yeah.
Good question.
Yeah.
Yes, madam.
Okay, so there's a fear factor in when you have a very high heart rate that you're not used to having,
Yes.
and the value of exercise, because those two things are like, tell me just the opposites of what I want to be doing.
Right.
So what do? You just go ahead and do the exercising that you ought to be doing, or wait it out?
Yeah. So I guess what I'd say to that is 2 things. One is that some people do see exercise as a trigger for atrial fibrillation. There are patients who have atrial fibrillation and exercise
As a trigger.
as a trigger, yeah. And actually, there are some studies that show long-distance runners are more likely to develop atrial fibrillation, believe it or not. So we're telling you to exercise, but don't run a marathon, okay? But
I think it's more than 20 miles a week.
yeah, they saw this. Yeah,
Research.
after 20 miles a week, they start to see an increased risk of atrial fibrillation. Yeah. To your point, though, like what you do in that case, where you're worried about the heart rate shooting up with activity, I will say that in those same trials where they looked at the lenient heart rate control versus the strict heart rate control, those were for resting heart rates. There's not a lot of evidence that there's any harm for elevating your heart rates during exercise. So if you have atrial fibrillation and you're using a stationary bike and your heart rate's getting up to 150 beats a minute, as long as you're feeling okay, that is all right. And when you rest and recover, the heart rate comes back down. That's perfectly fine. Yeah. Yeah, go ahead. Yeah. And teacher's pet right here. Yeah.
I'm just thinking, one of the things I saw was over-exercise can be a contributor
Yes.
to stroke. And I was thinking, I don't over-exercise, but I have a son who sometimes I think of as, man, he does everything.
Yeah.
But then I think, oh, this is kind of fascinating to see that little comment. And
Yeah.
Yeah, there is some studies that, and we do see that, so people that run a lot of marathons, and I, don't quote me on this either, but I believe the data was somewhere around 20 miles, that people that run more than 20 miles a week were at increased risk of atrial fibrillation.
The idea is that long-term the heart
Right.
is going through some fibrosis for those long periods of activity, and that fibrosis can increase the risk of
I feel better
Atrial
because his exercise is so varied.
yeah,
That
yeah.
I look at it and I just go, man, you're in such great shape.
Yeah,
But then
yeah.
I think of, he does a lot of exercise, so
Yeah.
the data course.
Typically, it's good.
Great,
Yeah.
great. All right, well, thank you all very much for coming. I hope this was informative. Yeah, thank you.